Welcome, everyone, to our Department of Family Medicine Grand Rounds. Apologies for being on Zoom for this introduction. I'm Ying Zhang, she, her pronouns. I'm an associate professor in our department. It's good to see everyone there in the classroom. I'm very excited to introduce our speaker today, a good friend, Dr. Richard Waters. Dr. Richard Waters is a family physician and addiction medicine specialist in Seattle, Washington. He works as the medical director for the Downtown Emergency Services Center, or DESC, where he sees patients for behavioral health needs and supports operations and program evaluation. He previously served as an addiction med lead clinician at Neighbor Care Health and medical director for Neighbor Care Health's housing and street outreach programs. He completed his residency and chief residency at our program at UW and at Harborview Medical Center, where he was my co-resident. And he did medical school at Duke University. His clinical interests are in providing high-quality healthcare with a focus on addiction medicine to individuals formerly or currently living homeless, guided by the principles of harm reduction, trauma-informed care, and a belief in the right of all persons to housing and healthcare. Thanks so much, Richard, and we're excited to hear from you.
Yeah, thank you so much, Ying. And just kind of testing folks online. Is audio coming through okay?
Yes, loud and clear.
Great. Great. Well, thanks so much for the invitation to the organizers, and really glad to be here. Like Ying said, I did residency here and recognize many of you. So it's great to kind of be back home. I've been in Seattle since residency, working in clinical spaces, really at the intersection of homelessness, substance use disorders, and serious mental illness. So here to talk today about kind of evolving strategies, treatment updates around opioid use disorder. This is not going to be comprehensive in any way, but shaped a lot by my experience at Neighbor Care Health, the community network of community health centers, and currently at the Downtown Emergency Service Center, behavioral health and policy. I have no financial disclosures, no conflicts of interest. I don't have any association with pharmaceutical companies. I wrestled with this question. I do want to use brand names of the long-acting injectable buprenorphine formulations, just to make it a little more educational. There are no generic formulations of long-acting injectable bupe, and it is going to be easiest so you don't have to do some mental gymnastics in your mind to use the brand names to gain familiarity with the product. Certainly, I am hopeful for a lot more competition and eventual generics. So we will talk about updates in OUD care related mainly to the outpatient setting, in large part because that is where I have lived and where my own kind of confidence and expertise lives. And I know that is going to be broadly applicable to family medicine. I'm really looking at kind of how does opioid use disorder care look differently today compared to even a few years prior? What might it look like in a few years from now? And certainly there will be themes about how primary care can get us there. Just a plug and a reminder, of course, this is not the first talk on opioid use disorder care. In March, there was a fantastic talk by Dr. Claire Simon on opioid use disorder. Just want to refer folks there if you haven't seen it. Very foundational, lots of good content. So just to start off, kind of fentanyl, of course, is the new unregulated, not new, but the predominant unregulated opioid in this locale and across much of the US. In the Seattle area, fentanyl appeared in large form in 2019, mainly in the form of these blue pills. They look like an oxycodone 30 milligram tablet. And when tested, they were about they were an R, so they're harder to find, about 1.7, 3.4% fentanyl. The rest is Tylenol or filler. In 23, and after that, fentanyl powder and fentanyl rock started to appear in the market. So more pure product. And in 2023, it was about 15 to 30% fentanyl, jumping in less than a year, 43 to 89%. So a really rapid increase in the purity of the highly potent coagulant opioid. And this data comes mainly from the King County Medical Examiner and police departments, which collect samples, what appear to be unregulated drugs at overdose scenes or other scenes, and they're tested by the medical examiner. In the lay press, lots of media attention to the fentanyl epidemic, to the overdose crisis. This is a graph showing drug overdose deaths that are presumed to occur from drug, based on what is in someone's system at the time of death in Washington state. The black line is opioids, all opioids, heroin, fentanyl, oxycodone. The gray is psychostimulants, mainly driven by deaths associated with methamphetamine use. And the blue is heroin. You can see in Washington state, deaths associated with heroin have dropped to very low, approaching zero, as deaths associated with synthetic opioids, like fentanyl, have risen dramatically. Deaths associated with psychostimulants, methamphetamine in particular, have also risen. There is thought to be a particularly potent combination of using a drug, like an opioid, that suppresses ventilation and decreases your oxygen, with a stimulant that can increase metabolic rates, heart rate, and the need for oxygen consumption, leading to potentially more, possibly a more likely, higher likelihood of dangerous arrhythmias when that combination is used. Deaths have dropped. So recently, as you can see, that the overdose death rates have dropped. It is not just in Washington state, but I do want to make a point that it is somewhat profound that in the last 3 years, approximately 0.09% of the Washington state population died from drug overdose death, or died from associated with drug overdoses. It is not just here. This is the same data pulled from the same source, CDC data for West Virginia. As you can see, there were increases associated with the prevalence of fentanyl, and death rates have dropped in the recent year. Deaths associated with psychostimulants, methamphetamine, have also increased and have dropped. West Virginia has borne a pretty horrific toll. About 0.17% of the population have died from drug overdose events in the last 3 years. The idea of drug use can sometimes be politicized in really problematic ways, and sometimes layered in a veneer that this is a liberal city problem. And it's worth just noting that this is a problem everywhere, as we know, in rural America, in conservative America, and West Virginia, rural areas have been particularly hit hard. Here's the question, these last two slides showing a drop. What is behind this? Are we, the public health, the healthcare side, are we doing something right? What is driving the improvement? It's uncertain based on my read of the data, and what my awareness of this is that this is not something anyone can point to with confidence and say, we know exactly what is driving the drop in deaths. Two leading theories are that one is somewhat tragic, that people at the highest risk of death have already died, and your denominator is now much lower. And so simply by virtue of a number of people already having been killed associated with unregulated drugs, there are less people remaining. The other relates to the illicit supply itself, that there have been changes across the board in the drugs in the US market that are of more consistent potency, less variability. It's kind of worth saying that it's not really fentanyl that is killing people, it is the unpredictability of the fentanyl dose, the uncertainty of the dose. We use fentanyl, of course, in hospitals, in healthcare settings all the time. But that unpredictability drives uncertainty, and there's very little room for error in a drug so potent as fentanyl, where on the order of micrograms or milligrams, right, someone may go over their tolerance. The news is not good for everyone, per se. It is not that drug overdose deaths are falling for all demographics. This is data from Georgetown, a few years old, 2022, 2023 data, showing that the overall rates of decreased rates of overdose deaths that we're seeing are mainly driven by people identifying as white, whereas there have been increases in those identifying as Black, Asian, Hispanic, or other demographics. So still ample work. So going to kind of what do we do? You all know this. This is probably no news to anyone. Can a medication treat addiction? Of course. With opioid use disorder, we have very powerful tools in the form of medications. Methadone and buprenorphine, the two gold standards. This is a systematic review, a few years old. The data is entirely from the heroin era. But methadone, being on methadone treatment, reduces all-cause mortality by about 2/3 compared to no methadone treatment. Buprenorphine, less, but still significant for all-cause mortality. There are very few things we do in medicine, in primary care, that affect all-cause mortality. And certainly, this is really just saying that the predominant cause of death is respiratory depression from opioids. Opioid poisonings or opioid overdose, and this drives a significant decrease in those events. But looking at all-cause mortality, we see we're not increasing other risks that offset that benefit. This can, highly effective meds, another stat that is probably well known, that it is not scaled to the magnitude of the need. Estimates from the CDC, 2024, looking at 2022 data, of a roughly 3.7% of the US population of adults who need opioid use disorder treatment, have an opioid use disorder, which is a pretty mind-boggling stat in and of itself, 3.7. Only about 25% received the medication treatment. There was another group that received non-medication treatments, but only 25% received a gold standard. And this is not even looking at kind of continuation or duration, but simply individuals who received it in 2022. This, so a big gap that could have a big impact.
Considering the fact that so many of the people that have dying have been Black, can we assume that the people that have been treated effectively are white?
There have been studies looking at racial disparities in treatment access. And while I can answer a general question, I may miss up specifics, but generally, historically, methadone access, highly regulated federal methadone clinics, have been placed in areas that have a higher, that are kind of disproportionately with Black or non-white, Black and non-white population, whereas buprenorphine has been rolled out and has been more accessible disproportionately to individuals who identify as white. So there are disparities in the type of medication, but overall medication access has favored individuals with more privilege in a variety of ways, disadvantaged individuals without privilege.
I recall, though, getting into a methadone program typically was very difficult.
It is not, granted, it is fairly easy here in this setting compared to others, and we'll talk a little bit about that in just a moment. But it is still not nearly as easy as it could be and as it is in other countries. Along with the medications, just want to note there have been a lot of studies looking at how do the medications do compared to other interventions. Residential treatment, going off somewhere for a month, 3 months, not using medication, engaging in intensive outpatient counseling, engaging in other forms of treatments that may be thought of as substance use disorder care. And it is only buprenorphine and methadone that really drive or that are associated with a reduced risk of overdose and a reduction in serious opioid-related acute care events. This can kind of grate against, at least for some, a maybe predisposed notion of what substance use disorder care should look like. Does this feel overly medicalized, too simplistic? We can treat with a medication. And while I think it's appropriate to think of all of the services that we need to provide people, including housing, behavioral health, primary care, to really maximize human benefit, well-being, public health, it is really the medications that drive a tremendous amount of the positive outcomes. There is this notion, sometimes in lay press, sometimes online, that we are replacing one addiction for another. We are taking fentanyl away, taking heroin away, and replacing it with another type of opioid. And a question sometimes raised by people from lived experience themselves, but is this a good idea? And it's worth just saying, you're not replacing one addiction with another. The hallmark of an addiction is loss of control. I don't want to use fentanyl, but I do. I don't want to spend my money on fentanyl, but I do. I don't want to kind of pay less attention to other obligations that I have in my life, work, family, health, but I end up paying far less attention potentially because of fentanyl. I have lost some degree of control, and for some that loss of control can be profound. These medications give control back to people. They are the opposite of an addiction. They are empowering people to make control about if they use, how they spend their money, how they spend their time, how they live their life. There is physiologic dependence on these medications as opioids, but it is not an addiction. So some updates, kind of what has changed? Where are we going? Methadone. Methadone has been around for decades, highly effective, somewhat stigmatized. In many ways, it is better than buprenorphine. All of the data, granted from the heroin era, if I am someone with opioid use disorder and my outcome that I want to achieve is living a longer life, a more fulfilling life, methadone tends to outcompete buprenorphine because people stay on methadone longer. Methadone has more complicated pharmacokinetics, more complicated drug interactions, but on the whole, because people tend to stay on methadone longer, their outcomes are better. Methadone in this country has been highly regulated. It's only accessible for addiction through federally certified opioid treatment programs that come with a lot of stipulations and regulations. It is worth noting, Dr. Claire Simon had also mentioned this in her talk, there is a rule that allows us, any of us, primary care clinics, could be here at Northgate, we are starting to do it at DESC, to dispense or administer, but not prescribe, methadone for addiction for up to 3 days. And then someone needs to make the jump to an OTP. We have purchased methadone from a wholesaler, we have it secured, we've set up a system where someone with an opioid use disorder can come in, they can get evaluated, we can dose them. And in an outpatient setting where you're not governed by some of the regulations of an OTP, there is more flexibility to increase that dose over those 3 days faster than some OTPs are able or willing to do. So there is some flexibility. I saw a hand, let me finish this and we'll circle back.
I just don't know what an OTP is.
Oh, sorry. Great question. Opioid treatment program. Opioid treatment program sounds very general, really kind of means a methadone clinic. So federally certified, lots of regulations, can use methadone for addiction. Yeah. So evergreen treatment services, therapeutic health services, We Care Daily clinics are the ones locally in Seattle. Fentanyl, people are coming into treatment, coming in seeking treatment with much higher opioid tolerance than they had in the heroin era. And what kind of the entire system is learning is that doses used in the era of heroin often don't cut it in the era of fentanyl. So higher starting doses, there are innovations in hospitals, Swedish, UW, for people who are admitted, of seeing can you get someone up to 60 milligrams on day 1, 80 milligrams on day 1. Can you get someone to 100 milligrams by day 3? Trying to do that starting dose and titration process faster because people are coming in with just higher tolerances that can tolerate these bigger doses. Maintenance doses are higher. It is not uncommon to see people now at methadone programs on doses above 200, 300, in some cases approaching 400. Obviously, these maintenance doses are not going to apply in the primary care setting because of regulations, but it's worth kind of noting that this is happening at the federal kind of opioid treatment programs, and in many ways is a very good thing. It keeps that tolerance high. It helps to reduce the risk of overdose. It keeps people feeling well. Methadone, of course, prevents opioid poisonings, opioid overdoses, by raising tolerance so high that unregulated supply, like fentanyl, just can't kind of overcome it. Your tolerance is already at a certain level. Your body can tolerate it. So if you use a potent unregulated drug, you can kind of withstand that.
So those patients that are on like the higher doses of methadone long term, are they weaned to lower doses, or are they staying on those high doses long term with good effects?
Disclaimer, I don't work in a methadone program,
Okay.
so my direct clinical experience is more limited here. My understanding is that it is safe. It has been safe and effective to keep patients on kind of higher doses. And obviously every decision is it's a shared decision-making process.
I think you were implying that there is safety in keeping people high for higher doses, because if they were to use again, then often people will overdose because they go back to their previous doses, and if they have a lower tolerance, then they're in trouble. Is that what you were implying?
That is what I was implying.
Yeah.
And I should clarify that I am, there may be data out there, but I'm not aware of really solid data in the fentanyl era saying, if you are on 140 milligrams of methadone versus 240, what do those outcomes look like? But in terms of kind of clinical theory and what folks are seeing, this is a line of thinking that appears to be holding true, but they need more data to really kind of solidify it, I guess. I will just note, sometimes I will flip between using the word patient and client. Client is a word often used in the behavioral health system, and now I'm living in the behavioral health system, and sometimes I will just kind of flip. I know that can be a little bit maybe off, like, why is he using client to people who live in the primary care building? Just a paper, don't take my word for it. Boston Medical Center is administering and dispensing methadone in the outpatient primary care setting and linking people with methadone. And finding that it's effective to create another access point for patients. Useful to know, there is a bill. It has kind of languished for a few years in Congress, but it would start to chip away at fortress methadone by creating a pathway for at least some types of physicians to prescribe methadone in an outpatient setting where the patient could pick it up from a pharmacy. It would be limited in its scope, but it would start to get the US more aligned to what most other developed countries are doing in terms of methadone treatment, where it is often managed within primary care. I want to pivot to long-acting injectable buprenorphine. Another great tool, we'll talk about the greatness or lack thereof, but another tool for opioid use disorder treatment. There are 2 brands in this country, and no generics, sadly, of long-acting injectable buprenorphines. Sublocade and Brixadi. And again, choosing intentionally to use the brand names just for familiarity. Sublocade comes in 2 doses, 100 and a 300 milligram, and they're monthly. They're considered monthly injections. Brixadi has 7 different doses. The top 4 are considered weekly injections. They have a half-life of about 3 to 5 days, and the dose ranges from 8 to 32. And then there's 3 injections that are considered a monthly injection. They have a half-life of about 19 to 26 days, ranging from 64 to 128. Key thing to remember is the numbers that you see don't compute to sublingual. It's kind of, you can't make an equivalent. 300 milligrams is not the equivalent of 300 divided by 30 per day. It doesn't work like that. But they are tools. They're administered subcutaneously, not intramuscularly, and never intravenously. But they go under fat tissue. They can go kind of in a lot of different places, Brixadi and Sublocade. Often in the belly, can be in the buttocks, can even be in the back of the upper arms. There's a promise for these medications, and that promise is higher doses and more consistent doses, higher plasma levels and more consistent plasma levels. This is from the package insert. Each spike that you see represents someone getting a monthly dose of an injection. Here's 1 injection of a 300 milligram dose. Here's another 300 milligram dose. And you can see every month, it's called the trough levels go up. The half-life of Sublocade is about 46 to 60 days, very long half-life. That is not because buprenorphine is any different of a molecule. These long-acting injectable they come in they have a delivery mechanism where the liquid medication that is injected under the fat tissue forms kind of think of it like a gel depot, a solid depot that then dissolves. The rate of dissolution varies from product. Sublocade's a little different from Brixadi, but often you get a stacking effect. And you don't really reach steady state for 4 to 6 months. Like any drug, you're not going to reach steady state until 5 half-lives. These are no different. You're going to reach steady state in about 5 half-lives. Half-life is about 46 days. 2 nanograms per milliliter on this slide, the bottom red, is thought to be, based on some studies where people come in and researchers whose IRB had a field day administer fentanyl to them and watch their breathing. 2 nanograms per milliliter is thought to be the plasma level that's going to be reasonably substantially protective against decreases in minute ventilation when exposed to fentanyl, or when exposed to a full opioid. 5, you're going to get barely any decrease in your ventilation. And it's going to start to really blunt most of the effects of fentanyl. Small studies, everybody's different, everybody metabolizes things differently, so lots of variation person to person here. But you can see that after several doses, you're getting up to 5 nanograms per milliliter. It is very hard to reach these doses with sublingual. Taking buprenorphine every day under the tongue, dissolving it, really tough to get to levels around 5 nanograms per milliliter. The other theoretical promise of these medications is that it's very forgiving in terms of dosing. It has an extremely long tail, long half-life. This is pharmacokinetic data from a study looking at someone who, looking at modeling data based on real world numbers on how buprenorphine levels would fall after 8 monthly injections of the 300 milligram dose. Get 8 in a row, and then imagine life happens, or someone travels out of the country, or someone moves and can't connect to a clinic. On average, they have about 5 months after that last injection to remain above 2 nanograms per milliliter. 5 months without getting any further medication when you have substantial overdose protection. Yeah, the gray is a confidence interval. You know, some people are going to metabolize it faster, slower. But this is really nice because you don't really need to show up right on time. You show up 6 weeks after your last injection, 8 weeks, sometimes even 12 weeks, depending on how many injections you've had. The person themselves may not feel that cravings have returned. And we see this in practice. People who have been consistent with their injections might have a 3-month, 4-month gap, come back and say, I feel like I'm ready for another one. Because I didn't feel any cravings for 3 months. And I thought it was fine. And then I kind of realized, yeah, it's time to get another one. Is it more effective, though? So there's this theoretical pharmacologic data, there's this promise, is it more effective in the real world, this long-acting injectable buprenorphine? Like most things, it probably varies, and it's not a universal yes-no answer. There's observational studies, the first one kind of switching from sublingual. People who switch from sublingual to long-acting injectable tend to have lower retention and care than people who stay on sublingual. But that's an observational study. The people who are switching to long-acting probably have something going on that's not working. And that switch may be indicative of something in their life that they're not happy with, a treatment effect that they're not getting. So observational, lots of caveats. Another observational study of 58,000 using claims data, starting long-acting injectable buprenorphine had lower retention than starting sublingual. Observational, lots of potential confounders. I could imagine that long-acting injectable might be chosen for clients who might be deemed riskier in the eyes of a clinician. And sublingual might be used more preferentially for folks who feel like they can have the better option for them. A post-hoc analysis of an RCT, 123 individuals with fentanyl, long-acting bupe had the same retention but better suppression of fentanyl use than sublingual. And an observational study of individuals with experiences with homelessness, either active or recent, long-acting injectable bupe had better buprenorphine coverage. Think of it as another measure of retention than sublingual. Fentanyl has made it harder to start buprenorphine. So we've got these medications that are highly effective, and it's been harder to start. In the heroin era, it was pretty easy to start buprenorphine in an outpatient setting for clients who were living homeless, clients who had housing, clients who had severe or mild or moderate use disorders. It was an easy bridge. And in many ways, my role as a clinician often was providing the medication, and the person in front of me knew exactly how to start it. They had experience, they knew how to do it, they had figured it out. And it was easy to cross that bridge back and forth. If they had a lapse and missed a week of medications, they could start back on their own, and it was easy to restart buprenorphine when using intramuscular or IV heroin. There always was a subset of people, though, who smoked heroin. It's a far less efficient way to get to use a drug because you lose a lot of the heroin when heated. But it is the fastest way. There's no faster way to get a drug to the brain than through inhalation. Faster than IV, faster than intramuscular. People who smoked heroin would often need to smoke every 2 hours, every 3 hours, and really struggled with starting buprenorphine. Had struggled with kind of waiting long enough before starting buprenorphine to avoid that risk of precipitated withdrawal. We're not going to talk about precipitated withdrawal like here. That's kind of assume that folks are familiar with it, but it's essentially a way that buprenorphine could make people feel sicker before better. Fentanyl upped this even more. Most people smoke fentanyl. It's highly potent and it's lipophilic. So it gets absorbed into fat tissues and then released even if someone stops using fentanyl. You start to equilibrate with the plasma. So the transition became even harder, at least for what clinicians were seeing on the ground. And so buprenorphine starting strategies, what is sometimes called the induction or the initiation methods, they evolved. There's been sublingual-based overlapping protocols, sometimes called microdosing or low-dose crossovers, effectively continuing to use the illicit drug, the unregulated supply, while increasing buprenorphine in tiny ways over days. It can work. Works really well in the hospital where you've got a lot of controls. In the outpatient setting, not great retention. A recent report showed about 22% retained in 28 days. Not bad, could be better. There's been this pathway of withdrawal first methods, high dose methods, or macro dosing. Stop using, put yourself in really bad withdrawal simply by waiting and not using, and then take a big dose of buprenorphine. In the outpatient setting, there is not a lot of success or uptake that I or local colleagues or kind of colleagues nationally in the outpatient setting tend to see with this, though there's not a lot of data in the outpatient setting. And then there's the naloxone assisted method. Not a lot of uptake and demand for this method, but it is spraying naloxone. If I am someone dependent on high doses of fentanyl, I take a naloxone, I spray it up my nose, I let severe withdrawal kick in a few minutes, and then I take a very large dose of buprenorphine. Getting to Sublocade or Brixadi, the long-acting injectables, there have been changes to try and make this process easier. But the package insert still says you got to get to be able to tolerate 4 milligrams of sublingual buprenorphine, and then you're good to move into the injection. But getting to 4 milligrams for many can be a real challenge. Some of us locally, both at DESC, University of Washington, and others, have offered and done what is known as a direct to inject method with Sublocade. So someone is dependent on fentanyl, they smoked 10 minutes ago, they receive a 300 milligram dose of Sublocade. Unpublished data, but it nearly always precipitates very severe withdrawal. And nearly everybody of that very selected, highly motivated population that chooses that method stays on the method and is thankful they did it. But it is not scalable, and it's incredibly poor advertising to everyone who sees them in the next few days. Patch in hospitals, you can use buprenorphine transdermal patches. It's got regulatory hurdles and cost hurdles in the outpatient setting. In the outpatient setting, the package label for Brixadi is this. It says tolerate 4 milligrams of sublingual bupe and then do a Brixadi 16 milligram injection. Then the next day, maybe do an 8. Then later on, top up with another 8, all in the first week. And then consolidate into a weekly or a monthly dose thereafter. Tolerating 4 milligrams of sublingual bupe is the rate limiting step. It is hard for folks to go from using fentanyl to be able to say, yes, I'll take 4 milligrams all at once. And the question that looking at this that presents itself is why start with a Brixadi 16? Why not switch to Brixadi 8? Could you then only need to get to 2 milligrams of sublingual buprenorphine? And is that easier for folks? So my colleagues and I at DESC did this. We said, we're going to switch. We're not going to have you start with a 16. We're going to have you start with an 8. Can you get to 2 milligrams? And there were some clients who came to us and said, I don't want to take any sublingual. I'm done with the sublingual. I've had precipitated withdrawal. I have negative associations. Please just give me the Brixadi 8. So with informed consent, we did, and they tolerated it fine. So really over the last year, within the Downtown Emergency Service Center, we kind of we developed this, what we're calling kind of an injectable only overlapping starting protocol. And I will also say this builds on work that many others have already started. So this is not coming out of thin air. Researchers at Yale, California, have been looking at what is called these direct to inject methods. When can you skip sublingual? The method that has been working really well, and we recently published in JAMA Network Open, is starting with a weekly 8, Brixadi 8. Don't need to stop fentanyl, don't need to take any sublingual buprenorphine. Start with a weekly 8 on day 1, get a 16 milligram on day 2, and then a monthly injection on day 3. No sublingual, and no need to stop fentanyl. Fentanyl cravings will naturally reduce as the buprenorphine levels increase throughout this process. There's some standard counseling that we give to people during this process, which is, you might feel dope sick. You might feel withdrawal symptoms, so expect that. And we can't give a guarantee that severe withdrawal won't happen. Everybody's different, and we have seen severe withdrawal, particularly after the monthly injection. We counsel people that continuing to use fentanyl during this process is assumed, and if they are going to forcibly try to stop, this method is not for them. They should use other methods. This is analogous to the counseling that goes with a sublingual overlapping process or a microdosing process. Use as safely as possible, and don't start sublingual buprenorphine until 24 hours after the monthly, just because people tend to take it too early and precipitate withdrawal. We published a study of an initial 95 patients who came to us and said, yes, I want to do this, order the medications. So we ordered the medications, got approved. 75% of that 95 eventually completed the process. And 64% of them went on to receive a second monthly injection. These were higher numbers than we had seen using any other method locally, and tend to be higher than other published methods. Though I will be the first to say we should be cautious against drawing too many conclusions from a single study with small sample sets. This is data from DESC's opioid treatment program. This is the number of new people coming every month, new individual coming every month and saying, I would like care. I've heard about your services. I'm dissatisfied about my fentanyl use. Can I enroll? In August of 24, we implemented this new protocol, and it caught on. People had great experiences and told their friends, and their friends came and they told their friends. And the number of new enrollees per month jumped and was really only limited by our own bandwidth to see them. We had to close down things in February to new enrollees because we couldn't keep up. This is the number of current active enrollees per month at the program. So people that we are kind of retaining in care, not necessarily everybody doing stellar. Some people are still struggling kind of to achieve the goals they set for themselves. But it skyrocketed. We're hanging on, we're kind of retaining people in care more, people keep coming. So this is one thing that gives us a lot of reassurance that this new method of starting buprenorphine is not only working well, but working well enough that our kind of net promoter score is pretty high. People are kind of spreading the word. I want to go through a few other things quickly. I'm aware of time, I want to leave some time for questions, but just a few other updates. Contingency management is a behavioral intervention strategically using material incentives to induce behavior change. 4 basic kind of steps of this: you set a goal, provide transparency on how to achieve that goal, objectively, non-judgmentally monitor progress, and provide an immediate incentive if that goal is achieved. Sometimes this is done with gift cards or immediate reward or like a prize. You get to select something. You might get something big or small. Really meant to be positive reinforcement, not punishment, and really trying to kind of harness this kind of dopamine pathway in a way that gives people something to focus on that is other than kind of the reinforcement from the drugs. Contingency management outperforms all other non-pharmacologic interventions. Has a pretty good effect size, medium effect size, and it's effective for a variety of outcomes. MOUD, adherence and retention, stimulant use, concurrent tobacco use. In Washington, in mid-2023, the 1115 Medicaid waiver that allows Washington more flexibility in how it uses its Medicaid funds, contingency management was approved. So right now, there are pilot sites rolling out using contingency management, up to $1,000 per person per year, focusing mainly on stimulant use disorder, but we could see this more in the future. This would be great. GLP-1s, glucagon-like peptide 1 receptor agonists. There are signals in the data suggesting this may be useful. Observational study, 500,000 patients with a history of OUD. Those who had prescription for a GLP-1 have a lower risk of opioid overdose. Lots of potential confounders here. If I'm going to a primary care clinic and getting a GLP-1, I may be doing better and focusing on other things than others. So, grains of salt. Again, observational, there's lower odds of developing various substance use disorders if you lose weight with a GLP-1 compared to bariatric surgery. In animal studies, affecting the GLP-1 receptor blunts heroin seeking in rats. Just don't want heroin as much. Clinical trials are underway. This is too early to say. There's a lot of hype around these. Too early to kind of say, yes, use a GLP-1, like liraglutide, semaglutide, or an addiction. Far too early to say. But worth when other indications are present, obesity, diabetes, maybe even prediabetes, considering using this for that indication, but with the possibility that it may support someone's use disorder as well. Ketamine does a lot of things. NMDA receptor antagonist, relevance and reward pathways, potential for kind of inducing neuroplasticity that tries to break apart this cue response behavior. Does a lot of other things. Blocks serotonin, dopamine, norepinephrine reuptake, and probably a lot of stuff you don't know about. 2 randomized controlled trials, both in Russia, used psychedelic dosing of ketamine, high dosing with ketamine-assisted psychotherapy. Did find a significant improvement in abstinence rates at 1 and 2 years. Ketamine in the US tends to be used in emergency department settings for the treatment of opioid withdrawal. This NMDA receptor seems to be involved in related to opioid withdrawal, and ketamine seems to be a powerful potential treatment for opioid withdrawal. Have to call out local heroes, Dr. Cindy Grande, Tom Hutch, both adjunct faculty at UW Family Medicine, published this recently using sub-dissociative doses of ketamine, troches, to facilitate buprenorphine initiation. So again, something that still needs more data, but something we might see at least in hospital settings or in the future. Very briefly, elsewhere in other countries, they're using different things. Safer opioid supply treatment strategies. Just want to highlight this because this is in the Lancet Public Health. very well done study, big study, impactful. We are near definitively not going to have safer opioid supply treatments in the US, but this notion, the notion is this: someone is using unregulated supply, quite variable in what you're getting. If people are provided with full agonists, let's say hydromorphone, maybe even fentanyl itself, with known doses of known quantities, does that improve safety? And this study says, yeah, probably does. This was looking at Ontario, Canada, large population cohort, looking at those who were prescribed safer opioid supply, often hydromorphone, with methadone, and they saw that there's a risk of a regression to the mean, but those who started on safer opioid supply or methadone, both were associated with less opioid overdoses, less acute care visits, hospitalizations, infections, and acute care costs. Models care delivery, app-based care, it's here, it's already here, and it's here for Medicaid populations. Several companies locally working, doing either buprenorphine prescribing or contingency management, kind of gamification in a tokenized way. Trying to really see how do you scale contingency management, how do you scale buprenorphine prescribing. I think this is great. We obviously have a long way to go. Let's see if we can get there with app-based telehealth. Assertive community treatment models, kind of going to where people are. This is something that DESC is doing, Downtown Public Health Clinic is doing, Harborview is starting to do, bringing care such as long-acting injections to people. In Seattle, Seattle is the first to have EMTs be able to provide buprenorphine under standing orders to people post-opioid overdose. Somebody has an opioid overdose, 911 is called, Seattle Fire responds, naloxone, oxygen, maybe CPR, person comes to, can consent, Glasgow Coma scale of 15, feels really bad though from the naloxone. A perfect time in a tragic situation to provide buprenorphine, to treat withdrawal and help kickstart medication treatment. Seattle Fire is doing this, and it's really good. DESC, I just got to kind of give a plug. Just opened our Opioid Recovery and Care Access Center, partnering with Seattle Fire. Seattle Fire provides somebody with buprenorphine. You want that person to be able to go somewhere, and ideally not the emergency room. So folks can come here. I just want to say thanks. Ran a little long. We just have a couple minutes for questions.
Thank you so much, Richard. I'm going to try to moderate a little bit. I know there have been some questions that have come in through the chat. And I think there were also some comments in the chat that helped to answer those questions. I guess I'll ask you, Jean Wong, are there any other follow-up questions from your chat questions that you wanted to ask Dr. Waters? Please feel free to unmute. If not, maybe we'll just go to the classroom for questions then.
Yeah, Eugene said he was good in the chat. I saw it pop up. This is your resident. Dr. Waters, thank you. This was a great talk. Also, I think the first Grand Rounds talk that had community participation was excellent. We had some folks watching in from outside. I let Claire know you gave her a shout out too, so thank you for that. The one thing I wanted to call in is you shared that data on the percent change based on race or ethnic minority, showing that white populations have been improving and other populations going in the wrong direction. I wanted to highlight the American Indian populations that were on there, the Alaska Natives, where it had just a very small percentage change, which might seem favorable. But my review of the data actually shows that this population has the highest rate of overdose deaths. And so even this is a small percent change, this is not favorable information. And if they had a greater percent change than even that, that would be incredibly catastrophic for a small population. So thanks for sharing that.
This is percent change over time rather than who is disproportionately affected. American Indian, Native American populations are disproportionately affected far more than other racial groups.
Ian Bennett, very nice to meet you, and I really appreciate your support of Claire and our work in the department. I'm a big supporter of integrated behavioral health, and I just wanted to make a plug for looking for opportunities for us to weave this kind of work into our integrated behavioral health programs. That includes the Behavioral Health Integration Program, the BHIP program, where we have a psychiatrist who is available for reviewing cases that we're managing as family physicians. We also have psychologists here in our integrated behavioral health program. So, for example, with the app tool that you're discussing, that seems like a perfect addition to the things that we can offer, as part of our work as primary care providers. So I just was curious where you thought family physicians, primary care physicians fit in all of the work that you're describing.
Yeah, expanding buprenorphine access is key. Creating clinics. Claire's talked a lot about trying to create clinic environments that are really conducive to people whose lives may have a high degree of kind of struggles with kind of keeping time-based appointments, day appointments, and who have been stigmatized often by the healthcare setting. Wraparound services are great. Primary care doesn't, it's pretty high burden to say primary care needs to get people housing and shelter and all the rest. But I think the more we create really welcoming spaces where people know I can go back there and talk to somebody I trust, even if things didn't work out, I think that alone is like a pretty big first step. How clinics do that, lots of different ways. Love the low barrier kind of drop-in model where you can kind of come in, talk with a counselor, talk with social workers, see a primary care doc, meet with a psychiatrist or mental health professional. And if there are primary care clinics who just take the step of getting people comfortable prescribing buprenorphine and screening for opioid use disorder, that's still a good step in the right direction.
Our ambition is greater than that. We've been doing, buprenorphine since it was possible to do, and have a high rate of people who are doing that. So anyway, I think the opportunities in primary care, it's not going to be for everybody, but there really are huge opportunities that and an eager primary care base of providers. Again, not everybody, but enough that really want to do that.
I think just key tangible things there. I know we're at time. Setting up a buy and bill program so that you have a supply of stock, Sublocade and Brixadi, and you can get reimbursed, allows a lot more nimbleness. Somebody is there right in the moment, and you can provide them with a long-acting injectable buprenorphine. Amazing. Methadone with a 3-day rule. That's totally doable. Requires close partnerships with local OTPs. But now you've got somebody in your clinic who says, I tried not for me, I'd like to do methadone, and you could start them and get them up to a higher dose, have them come back for 3 days, and then make that jump to an OTP. Another great opportunity.
Cool, thank you.
Following up
We have another question from the chat. Kate, do you want to unmute yourself and ask?
I think I'm unmuted. Can you hear me?
Yeah.
Yeah.
Yes.
Hi, I'm a family practice doc at the Olympia Butte Clinic, which is a low barrier clinic. And we have been doing the direct to Brixadi inductions. And we kind of started with the Brixadi 8, Brixadi 16, Sublocade 300, and then found that there was some precipitated withdrawal. So now we've gone down to Sublocade 100 on day 3. Is that what you all are doing as well?
Yeah, we don't have hard data to really say with confidence, but that's my impression that doing a Brixadi 8, 16, Sublocade 300 carries a higher risk of withdrawal after that 300 compared to Sublocade 100 or a Brixadi 128. So I think it's kind of a shared decision making for the person who says, I'm okay with some withdrawal, I'd like to get a bigger dose up front. Sublocade 300 may be the way to go. But for scalability, a Brixadi 128 may actually be the best, or Sublocade 100 that you're doing.
Cool. Also, and then just if you have time for a quick follow-up. So we were also real interested in trying to follow what you all are doing and go out to the encampments and like do it in the streets, but it seems to be some sort of legality issue with you have to have a mobile clinic unit or some kind of a structure. Have you all found a way around that?
Using pharmacy delivered patient labeled medications, based on everything we've talked about and assessed, this feels totally in line with regulations. Using stock medications from a wholesaler, not patient labeled, not pharmacy delivered, that gets a lot more complicated. So we do our outreach-based care by ordering medications from a pharmacy delivered to our clinic, stored, and then using kind of just a tracking kind of chain of custody mechanisms, taking it to permanent supportive housing, shelters, tiny home villages, encampments. So yeah, my assessment is you are not butting up against any compliance or regulatory issues when using pharmacy labeled patient delivered.
Got it. Okay, thank you so much. Yeah.
I have a question. Following up on the integrated care model idea in post. I know Evergreen treatment facility used to have acupuncture. I don't know if they still do. I did my preceptorship there, following the NADA protocol, which was begun at Lincoln Detox in the Bronx. And I'm wondering, have you considered incorporating acupuncture specifically? We ran a free clinic for veterans for 10 years as COVID had to close down. But I think it may amplify our benefits. And I don't know where your mobile sites or pilot sites will be located, but we consider that.
We have not, in short. I think if we can do, we would love to do contingency management, especially for stimulant use disorder, if possible. Tons of data. And if we are able to get more resources, get more bandwidth, I think that's probably where we're going to try and go if possible. But good point. And I just want to, for organizers, I know we are over time, and I'm happy to stay, but want to defer to the organizers on how long we go.
Thank you so much, Dr. Waters, for being here and for your talk today. I did want to highlight the slide up here, which is for our next DFM Grand Rounds talk on October 8th at noon. And we look forward to seeing you all there. I will defer to those in the classroom, I guess, to whether y'all want to stay on Zoom and allow more questions to Dr. Waters. It seems like this is a really engaging topic. Thank you for allowing me to introduce Richard, and have a wonderful day, everyone. Sorry, I have to get back to inpatients. I'm going to sign off.
There's a meeting next in this room. We'll wrap it up. Thank you.